I'd now like to introduce the moderator of our second panel this morning. This panel features representatives of several agencies that are overseeing the response to the substance use epidemic in our state. And who better to lead that discussion than the Cabinet for Health and Family Services Deputy Secretary, Christy Putnam. Christy was appointed by Governor Bevin to this position in May, but she's been deeply entrenched in Kentucky health policy for several years. She understands that better health is not only about better health care, but about education and employment and the economy. Please welcome Christy Putnam.
Good morning and happy Monday, everyone. I was very honored and appreciate the opportunity to come and introduce our panelists and then moderate the discussion that we're going to have. We at the Cabinet for Health and Family Services are grateful to each and every one of you here because you are all part of the process that we are embarking upon in Kentucky. We have a number of challenges regarding the opioid epidemic, substance use disorder in general. It is not a one-dimensional problem. Therefore, it's not a one-dimensional solution. It's going to take all of us really working hard together and really identifying unique and creative ways we can work together. With that being said, there are a couple of things that I want to say just to welcome everyone. I'm going to introduce all of our esteemed panelists who are here with us this morning. One of the things that I'd like to just share with all of you is Cabinet for Health and Family Services, from our perspective, recovery, along with many other human services issues, is a holistic family and individual thing. It's not just one part of a person or one part of a family. It is a combined approach across a number of different domains and social determinants and approaches to behavior and really community approaches. I was fortunate enough to go to a conference last week in Seattle that was the Association for Public Human Services Administrators, and there was a statement, there was actually a panel similar to this one that included someone from the medical and behavioral field, and then we had law enforcement and drug enforcement agency presence there. And the statement that I'm going to read to you was the overarching statement that was made during this panel, and I just thought it was so powerful that I wanted to share it with all of you this morning. The opioid epidemic is a manifestation of long-standing challenges related to behavioral health and substance use disorder. It demonstrates the need to align activities across domains and jurisdictions at the local, state, and federal levels. Alignment and coordination require timely and actionable information at an individual level as well as at a system level. Data must be available to inform oversight into the access to and quality of programs, as well as to support research to improve upon prevention, treatment, and recovery. And that just, to me, just seemed to capture really well how important, how critical it is that all of these different agencies work together. So with that being said, I would like to go ahead and introduce our panelists this morning, and then I'll invite them up one by one to go ahead and talk about what they have to talk about from their perspective, and then we'll have some questions and answers at the end. First, I'd like to introduce to you Dr. Alan J. Brenzel, Kentucky Department for Behavioral Health. He was appointed the medical director for the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities with Cabinet for Health and Family Services in 2010. Before that, Dr. Brenzel served as the medical and psychiatric consultant for the Department for Community-Based Services. He attended University of Louisville School of Medicine and completed a combined residency in pediatrics, adult psychiatry, and child psychiatry at the University of Kentucky. He's also completed his Master in Business Administration in 2006. He joined the UK faculty in 1993, where he's an associate professor of psychiatry and pediatrics. Dr. Brenzel is actively involved in healthcare services reform in Kentucky, and I've had the honor and pleasure to work with him very closely on a number of different projects, including Kentucky Health. Second, I'd like to introduce Rick Sanders, Commissioner, Kentucky State Police. Rick Sanders was appointed commissioner in April of 2016 by Governor Matt Bevin, so he has served us now for 2.5 years as commissioner of the Kentucky State Police. He has served for more than 40 years in law enforcement, began his career as a police officer in the Jefferson County Police Department in Louisville, Kentucky in 1973. You must have been 10, right? Yeah. Yes, okay. Just checking. In 1983, the commissioner joined the Drug Enforcement Administration as a special agent within the Louisville, Kentucky resident office. He is a native of Louisville, Kentucky, has a Bachelor of Science in Police Administration and a Master of Science in Justice Administration from the University of Louisville also. And he also told me to make sure that I say he's just great. So I want to make sure that you know that Rick Sanders he's just great. So we're glad that he's here today. Last but not least, certainly I'd like to introduce Todd Keeneline. Did I say that right? Okay, close enough. Keeneline. There we go, Keeneline. Drug Enforcement Administration. DEA hired resident agent in charge Todd Keeneline in August of 2004. Upon graduation from basic agent training at Quantico, Virginia in December 2004, resident agent in charge Keeneline was posted to the Fresno office in California as a criminal investigator in an enforcement group. And after 6 years at that office, he was selected for an extremely competitive position as a special investigator in Cartagena, Colombia, where he was charged with working closely with Colombian counterparts in the fight against major cocaine distributors throughout the country. So obviously has some very firsthand frontline experience in taking a look at where the drug problem really starts. Upon completion of the tour in Cartagena, he was transferred to the Detroit Field Division in December 2012, and while assigned to the tactical diversion squad, he was responsible for investigating the diversion of pharmaceutical narcotics, mainly by registrants and pharmacies. In June of 2016, resident agent in charge Keeneline accepted a promotion to the position of resident agent in charge at the DEA Lexington office in Lexington, Kentucky. And he serves there now, and that covers 41 counties within the Eastern Division of Kentucky. So please join me in welcoming our panelists this morning. So what I'd like to do now is we're going to take a look at this from several different perspectives. First, we're going to take a look at it from the behavioral and addiction perspective, and I'm going to invite Dr. Brunzell to come on up and present his information.
All right, good morning, everyone. It's these lights are bright, and it's a little warm in here, so hopefully I'll make it through this without, but I suspect there's a few medical folks here if needed. So I'd like to thank Christy Putnam for that warm introduction, and thank the Foundation for Healthy Kentucky for highlighting this very important issue. I have the pleasure of serving as the medical director, as you mentioned, in the Department of Behavioral Health, but I represent many agencies during this agency forum. And so in the audience, I see my colleagues in the cabinet from the Department of Public Health, Dr. Howard. I know my colleagues here from the Office of Health Data Analytics, our Department of Community-Based Services, our Department of Medicaid Services. What I'm here today is to represent those agencies and to share with you overall our strategy and the level of coordination that we are undertaking to mirror the level of grassroots community organization that is occurring around this issue. Sometimes government learns from the people, and in this case what we've learned is that we're not going to solve this unless we all work together at both the executive branch level, the legislative branch, as well as the judicial branch. And so I have the pleasure of representing many folks here today. Everyone has their numbers and their statistics, and I tried my best to delete all of these last night, knowing that the first panel was going to cover this, but I couldn't manage to get rid of all of them. But I wanted to show a few. This is the slide that causes us all to just be incredibly frustrated. This is the number of overdose deaths from all drugs in Kentucky since 1999. You can recognize that curve. That trend line is not down. That trend line is not level. That trend line is up. Despite all of our efforts, we still continue to have a 10% increase between 16 and 17 in the number of overdose deaths. That is why we are all so frustrated and we all feel so much urgency. I am hopeful. I am convinced we're turning the corner, but the problem is this complex problem keeps evolving and keeps changing. And the game changer, I think Dr. Compton referred to earlier, the game changer has been fentanyl. This slide illustrates that the red line is prescription drug overdoses. That's leveled off. The green line is prescription opioids. The red line is heroin. Overdose from heroines have leveled off. But unfortunately, what you've seen is that purple line is where fentanyl is. So this is a 2016 slide, and I can tell you, unfortunately, in 2017 we had 763 deaths. So nearly 50% of our deaths now are related to synthetic opioids, primarily derivatives of fentanyl. We in Kentucky are fifth in the country now, depending on how you count it in overdose per capita. We were third. I'd like to think that's progress. Unfortunately, it's just that others increased more than us, and our numbers continue to increase. I also like to highlight the age groups with the biggest increases. It's the 35 to 44-year-olds, and second is the 45 to 54-year-olds. So this impacts individuals of all ages and is not primarily related to individuals between 25 and 34. Just a few numbers to highlight where we are. I mentioned fentanyl deaths are up, heroin deaths are down. We do have other drugs that cause overdose deaths, benzodiazepines being a significant cause. We find a fair amount of gabapentin now in our overdose deaths. It may not be the cause of deaths, but it's symptomatic of the polysubstance abuse that's occurring. One concern we all have now is methamphetamine is increasing dramatically. But those last two, prescription opioids, you can see both we experience declines. A big problem for us is the number of individuals who are pregnant, who have a substance use disorder, who are delivering infants exposed. This is another trend line that doesn't require any explanation, but this only represents individuals where the infant was assessed, diagnosed, and treated. We do think this is a significant underestimation. I'd like to find one slide with some good news, and this is a quarter-by-quarter, 4-year trend of ED overdose visits for all drugs. And we now have 3 consecutive quarters with decreases. We hope this is the beginning of the corner. I have to be hopeful that this is the beginning of the corner. We all know how impactful this crisis is for all of us. It is infecting many agencies that I represent. We have a record number of individuals incarcerated in our state system. If Secretary Tiller were here, he'd be pounding the podium talking about the impact on the correctional system, and my colleagues will do that as well. Our child welfare system, this number is now out of date. We have 9,500 children in out-of-home care, largely based on the impact of the opiate crisis on families, and then the economic impact of the opiate crisis on our healthcare system. You're going to hear from Dr. Hoven later and others discussing that, not hepatitis risk, HIV risk, but also cellulitis, endocarditis, brain abscesses, and the overall impact. So we do have a plan. I want you to leave here to know that the executive branch and the cabinet has a comprehensive plan that identifies targets. Our targets are not all of the issues that we're addressing, but we prioritize, and I'm going to try to, in a very short amount of time, give you some examples of each of those. These are all the agencies that I mentioned. We've got the Cabinet for Health and Family Services. In the box on the side, you see that it involves behavioral health, Medicaid, child welfare, the Office of Special Children with Special Health Care Needs, the Office of Inspector General, and the Office of Health Data Analytics. And then you see that Justice and Public Safety is one of our biggest partners, and so I'm excited to have Commissioner Sanders with us here today. The Office of Drug Control Policy is where Van Ingram sits. He's with us on a daily basis. I'm sure he would be here today if he wasn't in Washington, D.C., advocating for this issue. But also education, labor, administrative office of the courts, and then our leadership from the governor's office on this issue. So here's the components, the building blocks of our plan. Underneath, we have infrastructure, and we divide our interventions into 3 buckets: prevention, treatment, and recovery. And we have to have all 3. I think we heard that loudly from the panel earlier. Prevention is critical. Treatment is absolutely essential, but recovery supports are the new frontier and part of the missing piece that I think was so well highlighted this morning. So I'm going to try to highlight some projects in each of these areas very briefly. So prevention we can divide into the prevention of the initiation of use, the prevention of the trajectory from misuse to substance use disorder, and then preventing related harm, which in our world is sort of tertiary prevention. That's where our public health colleagues have become such valuable partners. So we are trying to expand access to universal prevention with funding made available to us, and that's one of the positives in this. We are now accessing considerable federal dollars that come to us through the SAMHSA through HHS. We serve in a coordinating agency and receive those funds. It's a significant amount of resources. And in each of these buckets, we have prioritized projects. So we're promoting many evidence-based prevention programs. This is just a list of a few. But that last one is the one I thought was maybe missing from this morning. We really have to get to the roots of adverse childhood experiences. We now know that how our children live and what they're exposed to early in their life has everything to do with how they function as adults and what their health outcomes are, including their risk for a variety of health conditions, hypertension, obesity, likelihood of tobacco use. But substance use disorder is certainly related to adverse childhood experiences. And so that's where we're also working with many partners. So we still know that most individuals, the numbers vary from 2/3 to 3/4, who develop an opiate use disorder start with a prescription opioid. And so one of our goals has been to limit exposure to opioids. And so this is a graph that shows the rates of opioid prescribing in Kentucky from October 2015 to fourth quarter of 17. The trajectory is down. Would I like to see that more steeper? Yes. But there are a variety of ways to do that. But one of that is, I think, as a physician and as a prescriber, we now recognize our role in creating this epidemic. And our healthcare organizations and our physicians and prescribers are now ready to be part of the solution and are ready to help. It's not about blame. It's about let's recognize the error of our ways and how we missed this spark that was illustrated earlier, and how we as organizations have to be part of the solution. And so the term we like to use is opioid stewardship. I think you're going to hear from Dr. Chang at UK and some of his colleagues later. But our organizations need to look across their own providers and prescribers and use data to understand how many folks are being exposed to opioids. Is it appropriate? For who, for how long, and how much? And this involves a national trend as well. We're working with some of our physician professional organizations. The Kentucky Academy of Pediatrics, the Kentucky chapter, is working to work with families to do drug disposal. That's one thing we have to do, is get these opiates out of our medicine cabinets. This is where our kids are getting exposed, is that folks have these in their medicine cabinets. So providing a pouch for disposal, having a conversation, sitting at the kitchen table and talking with your kids about why we're getting rid of these specific prescription medications because of how dangerous they are. We're also working with UK Healthcare, as I mentioned, around opiate stewardship. Take-back programs, I think Nancy Hale highlighted those. That's a very important way to eliminate the amount of opiates that people could be exposed to. We've worked very hard with the CASPR system. Most of you know what the prescription drug monitoring system is in Kentucky. It's a tool for prescribers that allows us to potentially identify someone who may have or be in the process of moving from opiate use to misuse to opiate use disorder. And we as medical organizations, I have to admit, resisted this development, but I would not practice today without this tool. This tool allows us to help those that we serve by understanding where they might be in this pathway. We're working in the cabinet to enhance this system. We're now linking it to criminal records that might indicate the person has a drug-related offense. And we're also trying to provide prescribers with opiate toxicology and drug screening results that may have occurred in an emergency department. These are things that would cause me to have a different conversation with a patient and to be able to suggest that they need treatment and that we need to understand their use. And so this is very exciting. We, with the governor's leadership, we did pass a 3-day limit on prescribing for acute pain. This is in some ways, it's disappointing that this is necessary, but I can tell you where I sit, the number of 30-day prescriptions is still inappropriate for very minor procedures, including dental procedures, sprained ankles. We do need folks to not reach for the reflex prescription pad of a 30-day supply. This is a graph that shows we've already made an impact in a short amount of time. This is the percentage of prescriptions that are for opioid analgesics that are 3 days or less. And that number is going up. It's still only 17%, so it shows you the burden of prescribing is still there, and that we do have a lot of individuals receiving chronic prescriptions. One thing we're missing that we need to solve is, and you're starting to see this, what about the legitimate pain patient who needs high-quality, evidence-based pain management. It is part of the answer. We need to look at, are we providing folks with non-pharmacologic interventions such as physical therapy, occupational therapy, other forms of mindfulness? We need our payers to recognize that it shouldn't be easier to get a Lortab or a Percocet than it should a prescription for other non-pharmacologic services. And so there are many things we need to do there. Back to prevention, we're at harm reduction, Narcan distribution, a major public health issue. Our Surgeon General was here not long ago up in northern Kentucky, and he said this is as important as learning CPR, because your likelihood of being able to save someone's life if you have Narcan is almost as great as someone having a heart attack. It's that common in our community. You can certainly ask our first responders how often they're utilizing this. So we're working very hard with our Department of Public Health to distribute naloxone, to prime the pump in our communities, to recognize that it's available in pharmacies. Our Pharmacy Association and our pharmacists have stepped up to make it available. Our payers and managed care organizations have stepped up, and it's really critical. I think I've been quoted to say that it should be on every guardrail in Kentucky, but that is almost true in a sense that we're finding individuals slumped over in their cars on the side of the road after an acute intoxication who are not breathing, and we need to be able to save those folks. But we're working to make sure that our retail pharmacies dispense, but our treatment centers need, no one should leave an opiate use disorder treatment facility without Narcan. They are very likely to go back into settings where they can save someone's life. And so we're excited to be partnering with them to provide naloxone. Folks shouldn't leave jails or substance abuse treatment programs in our state correction system without Narcan. And our emergency departments are a critical role. Where we all know, and I won't talk in great detail about our harm reduction syringe exchange programs, but it's something I think that we're all very proud of. But what we're proud of is that our community stepped up, and they decided to go through the process of forming a coalition, working together, addressing this issue. And so we now have, I think I asked Dr. Hovind, 45 communities who've done that, and we also have at least two more pending. I just got the 1 minute, and that was the first one I got, so I'm a little... But I do want to talk about treatment. So we've got prevention, treatment. The key thing I want to talk about treatment is we have to build a comprehensive array of services and understand that when a person is ready for treatment, that there's a hand there greeting them. And we aren't yet there. The whole message I want to give you is treatment on demand. We have to not let people walk away with treatment. This is a kind of a public health model for what you do when you intervene in a condition. First of all, you figure out how many people have it. Then you figure out how many are diagnosed. Then you figure out how many receive treatment. Then you figure out how many people get evidence-based treatment. And then you look at relapse prevention. The only blocks we have filled out in the SUD epidemic is how many people have it. And we know that only 12% of individuals who have it are in any form of treatment. We've got to flesh this out. We want to have universal screening part of our healthcare system. SBIRT is an evidence-based tool. I think Nancy Hale referred to our website and our call-in centers. We do have Find Help Now, Kentucky.org, where a family member, an individual can get and find appropriate treatment for their loved ones or for themselves. We have the call line. We are promoting what Dr. Totto earlier referenced as the ASAM dimensions. I won't get to talk about that right now. Access to quality medication-assisted treatment is a key part of the solution to this. A subset of these individuals will need medication-assisted withdrawal or medication-assisted treatment, and we need that to be high quality and delivered in combination with psychosocial supports. We also have a treatment stipend program, and I have to comment that Project Unite has been our key partner in getting these funds out to communities. Right now, if you're a provider and someone presents to you and you're eligible to participate, you have to be a licensed treatment provider, and that person has no payer source, we can reimburse you through these funds. No longer should inability to pay be a reason for a person not to get treatment. And we need to continue to get the word out that this is available. I won't have time to talk about the 1115 waiver, but there are many elements in the state's 1115 waiver under Deputy Secretary Putnam's leadership that will improve our ability to address substance use disorder. And one of those is our ability to waive the IMD exclusion, which limits residential treatment providers to 15 beds. we're very excited about that option. But it also involves these other things. It will require us to develop quality standards. It will allow us to have criteria for medically frail status so that an individual will maintain their Medicaid eligibility during their acute treatment. But also, we want to count their recovery activities toward the community engagement requirements. Recovery, it does involve community engagement, and so we want to partner to make sure that these folks return to employment and return to productive life. I will skip through. I do want to, maybe during the question, we can talk about how important we think emergency departments are. This is a new frontier for us. That's when a person overdoses, they should not leave that emergency department without an opportunity to engage in treatment. For us, that involves having a peer support specialist, meet them there. But it also involves that physician being able to look them in the eye and say, you don't have to go out and get another fix. You do not have to go out and obtain illicit supply. I can treat you today, right now, this minute. I'll walk you down the hall, around the corner, across the street, wherever it is, and I can manage your withdrawals. Because individuals who are dependent fear withdrawal more than they fear death, and we have to be able to treat that. Pregnant and parenting women, another population. I know I've seen some representatives of our high-quality programs that provide specialized care. These women need special care, but they also need those recovery supports. I heard of a case 2 years ago where a woman with a newborn who left a treatment program was given a bus ticket to a shelter with her baby in Columbus, Ohio. That was what was available to her. How do we expect a mom and a baby with a substance use disorder history, now in early recovery, to survive in a shelter with a newborn? It broke all of our hearts. And so, but I do want to just lastly highlight that what we've heard today is recovery supports are a critical variable. And with some new funding that we have, we fully intend to support things like housing and employment supports, and these recovery support organizations that will make sure that folks know that the community cares, and we're giving them a hand up and not a hand out, and they have a shot at long-term recovery. So I'll stop there and apologize for going over.
Thank you very much, Dr. Brunzell. And now we'll ask Commissioner Sanders to come up and give us a different perspective from law enforcement.
Thank you, Christy. Good morning. I'm Rick Sanders. I'm a recovering Louisville Cardinal fan. And it's really tough to come to Lexington this morning after your great victory. But, on a serious note, I said during the first panel discussion, and I went up and spoke to Ann because I heard what she had to say about the lack of law enforcement's response. And I think it's important that we hear from people like Ann. And I think it's important that you know how I got here. As Christy said, I'm a 40-year law enforcement officer, spent time with DEA, retired from DEA, at which time I actually worked in Miami during the 80s, during the cocaine crisis. I ran the Chicago Field Division for 5 years, from 2000 to 2005, when I was asked in Chicago, does Kentucky have a heroin problem? And I said, no, we don't. Because in Chicago, that's all we worked primarily was heroin and cocaine. That's where I was first introduced to fentanyl, where they were going in and stealing patches from nursing homes. But then I retired from DEA, became the police chief in Jeffersontown, a small community in Louisville. I was there for 9 years. And one day I'm in my office, and my assistant chief comes running into my office, hysterical, and I said, what is wrong? He said, Chief, it's my daughter. She's dying of an overdose. So I drove him 5 blocks from the police station. His 25-year-old daughter was laying in the living room floor dead. And after that, the mother of this young lady came running in, and I had to protect the crime scene. And I said, look, I know you want to be with your daughter, but let me protect the crime scene. Then I'll let you spend as much time as you need with your daughter. And I did. The coroner came, pronounced death, and I let that mother come in and hold her daughter for 20 minutes before we had to carry her off on a stretcher. And then one day I heard that one of my officers' twin brother died of a heroin overdose. So, it became very obvious to me that we need to do something different, and we need to do something to help those people that are addicted. So I did some research, and I had a real aggressive young female sergeant, Brittany Garrett, on my police department. We did some research, and we invited Chief Lenny Campanella to J-Town. He started the Angel Initiative in Gloucester, Massachusetts. And what that is it opens the front door of the police station and invites people that are addicted, people that have chemical dependency, to come into the police station, and will facilitate getting you into treatment. We were very much in the throes of that when I met with the governor. I threw my name in the hat to become commissioner of the state police. I had never met Governor Bevin at all, never knew much about him. But I was interviewed along with 17 other candidates, and my name was submitted to the governor. I went and met the governor for an hour and 15 minutes, and an hour and 14 minutes we talked about addiction. He heard of what I had done in J-Town, what I was doing in J-Town, and he said, "Rick, do you want the job?" And I said, "Yes." That was April 1st, 2016. So what can I do now as the commissioner of the Kentucky State Police, where we have 120 counties, 16 post areas that are all very different? It's like having 16 police departments. But I said we're going to expand the Angel Initiative. One of the first things I did was hook up with Nancy Hale. And I've told her husband, I love Nancy Hale. She is a tremendous woman who has passion for this, and I'm proud to be a partner with Nancy Hale in Operation Unite. But I've told her many times we need Operation Unite in 120 counties, not in 32 counties. We need to expand that program statewide and let the state police be a part of it. So what I did is in September of 2017, I went to Pikeville, Kentucky with Nancy's help, and we had an open door, and we invited people to come in to talk about the Angel Initiative. We did a soft rollout then in our Pikeville and our Richmond offices, our post, because those were the two that were most needy and, more importantly, ready to accept that responsibility. And then we had a hard rollout, April of 2018, where we actually opened the door to our 16 posts and said, if you have a chemical dependency, come to the state police and we'll facilitate getting you into treatment. Went over to Western Kentucky and met with Pat. We did a lot of work over there. And I'm proud to say, as of today, after rolling out the Angel Initiative, the Kentucky State Police has placed 47 people into treatment. But I've heard it said, and I couldn't agree more, that treatment has to be immediate. You can't have somebody come to the post and say, "I need treatment," and the troopers say, "Well, we'll get you in treatment in 2 weeks." That doesn't work. So our challenge was to those people in the treatment environment to work with us to guarantee us a bed if we brought somebody in. And I'm going to be honest with you, we're still learning how to do this because, as I said, our 16 posts are all very different. And these are challenging times for law enforcement. Not only do we have the addiction problem, but we've also got a real problem with violence in our community. And I do think a lot of that's being brought upon by the methamphetamine problem that we're seeing throughout this state. One other thing I did when I became commissioner is I started a critical incident response team where I got the most talented troopers and put them on a shooting team. And we respond to officer-involved shootings throughout the state. In 2017, we responded to 31 officer-involved shootings. So far this year, we've responded to 25. In most of those cases, methamphetamine plays a role. That and domestic abuse. So we have many challenges, but Ann, I'm not making excuses to you. We need to do better, and we are doing better in some areas. Alan Brenzel and I have become very good friends, and I love listening to him speak. And we talk about how do we approach this from a team concept and actually make a difference. It's not the way it needs to be, but it's certainly better than it was when I became a police officer a long time ago. We have to change two cultures. First of all, we have to change the culture of law enforcement to accept this is our responsibility. You know, my grandson asked me one day, he said, "Papa, do you lock up bad guys?" I said, "Cameron, we save lives." And I believe that in my heart. That's what we're here to do. So we have to change that culture. The other thing I did in Jeffersontown when I was chief there is I issued Narcan to every officer that I had. And some officers looked at me like I was crazy. And now at the state police, we have issued Narcan to every trooper on the highway because it's come in handy a lot more than we think. I had my command staff eating lunch 3 weeks ago in a local restaurant, and somebody came running in and somebody was dying in the parking lot of a heroin overdose, and they happened to be in uniform and went out and helped save this guy's life. The second thing we have to do is change the culture of those chemically dependent, that you can trust law enforcement. To walk into a station, think about how bold that must be to walk into a station and say, I need help. But I'll tell you one more story. While I was at J-Town, when I announced these initiatives, I had one sergeant, an old crusty sergeant, who came to me and said, Rick, you're crazy as hell. I mean, this isn't our job. After I left J-Town and went back to J-Town, I went to Gaslight Festival, pulled into the parking lot. Well, let me say also, before that, this crusty sergeant's middle son died of an overdose. So I walk out of my car into the police station at J-Town Police Department, and I see this couple and a young man get out of their car. The young man was probably 95 pounds soaking wet. It was obvious to me why they were there. And I saw this sergeant come walking out the front door. He was the angel to receive this young child. And I saw him take the mother and the father and that son and embrace and say a prayer for this young man. And then I saw him take him inside and facilitate getting him into treatment. That's an accomplishment. We've come a long way, but we still have a long ways to go. Alan mentioned that my boss, John Tilley, is very passionate about criminal justice reform and helping inmates that are incarcerated get the help that they need so when they're released, they can be productive. And trust me, I make no apology for arresting people. That's unfortunately what we have to do. But if we arrest somebody that's robbed a liquor store and we take them to jail, they have to be able to get treatment. And then they have to be able to be taught how to live when they get out of jail. Alan also touched upon it. I've been around a long time, but in the 70s, we incarcerated about 3,000 inmates throughout this state. In the 80s, it went from 3,000 to 5,000. And this year, we have incarcerated 25,000 people. A lot of those are women that have addiction, chemical dependency issues. We've got to think this thing through. And we in law enforcement have to be a part. We have to get out of our silos and have police, treatment, and professionals working together to try to do something about this tremendous problem we have. I commend Operation Unite for what they do. But I think we need to expand that to the 120 counties because, Pat, we've talked many times before, what do we do in western Kentucky? I know we have a tremendous appetite for methamphetamine. Alcohol is still a problem. So we need to do what we can to work together to get people into treatment. One other story, and again, I hate to even have to do this, but when I was the chief in J-Town, we had a young guy go into Cooch Liquors. That's a liquor store that everybody knows not to rob because their gun's bigger than yours. But this young man who was addicted to heroin with his 2 or 3 friends, I think it was 3 people in the car with him, they took him to Cooch, dropped him off at the front door. He went in with a fake gun that looked like a real gun. I couldn't tell the difference. To hold up the liquor store, the guy behind the counter pulled his gun and shot him in the chest. The kid survived. I can't believe he was able to survive, but he did. He came rolling out the front door, jumped in the car. His 3 friends did what friends do. They took him around the corner and dumped him out in the parking lot. So we responded to that as well. And that young man, hopefully, is getting the treatment that he needs to prepare him for when he gets out of jail. We cannot continue to treat this as voodoo. This is a real problem. We have to address it. We have to quit, calling people names that have this problem and deal with it to help those that have chemical dependency. And I commit to you, Ann, I'm going to do that. And I'll talk to Lexington PD. I don't run Lexington PD, but I know the chief, and I'm going to tell him about your conversation this morning. We are really doing something unique at the state police. We need to expand that. We as a community need to address this problem. Thank you for having me.
Commissioner, thank you very much. And now for a final perspective, it's one thing to make changes at the local and state level, but there are sometimes complicating federal partnerships that we have to negotiate as well. So I'd like to invite Agent Keenline to come on up and tell us about that.
Okay. So I'm not sure who really thought this through by putting a current DEA agent after a former retired boss of the DEA. So it's a lot of pressure that they're putting on me to be able to put something together. So, but thanks again this morning for having me, gentlemen. Christy, it's an honor to be here in the presence of you all. And again, thank you for allowing me to shed some light on some of the trials that we're going through within the DEA. And just so you know, I'm sure you guys are going to get overwhelmed with a bunch of PowerPoints like this one. So I apologize in advance, but just know that I had like 100 slides that when I hit send on the email, it wouldn't go through. So I had to narrow it down to like 25. So I'll try to be short, but really it's an important factor because this exchange is going to highlight not only the DEA response, but the state and local counterparts that join together to be able to help combat this epidemic along with the communities that we're a part of. And I will apologize as well that I'm going to jump outside of Kentucky because we are a federal agency and we're covering a lot of different areas, but I will bring it home to show that we're really here in Kentucky to support the communities. So these first couple slides are just going to kind of highlight the shift in the drug threat. So if you would just bear with me for these first couple. So as you can see, the heroin has been on a rise for the past handful of years and continues to do so. And through these slides, I want you to keep in mind and look at 2013 and see what happens. So I'm going to go through a couple, and I'm not going to talk about all of these, but you can see that these drugs are a predominant part of, unfortunately, the communities, and this is what we have to deal with. So as you can see, the meth has been consistent around the country, but it still remains at a high level. So you can see it's at 35% and remains there. So that's obviously a concern for us. And then you can see on the next slide, these are the controlled prescription drugs, which is, in my opinion, really what got us started in this epidemic and the spiral of what we're seeing today. So again, take a note in 2013 that you see a decline in the amount of prescription drugs, but of course the increase of the heroin. So I would like to think that as an agency and as a community with state and local law enforcement that we're doing a good job, and I'll explain a little bit further in the slides as far as how we got there. But I think we're doing a fair amount of good job getting, as far as 2013, reducing the amount of prescription drugs that are out on the street. However, that's just a never-ending cycle where you got the decrease in the prescription drugs, then you got the heroin, now the new mix of fentanyl, carfentanil, that is continuing that epidemic that we're seeing today. These last couple are just not to minimize these drugs, but marijuana and cocaine have been on a typically downward spiral for a little while, so that's good news. Again, expanding outside of Kentucky, I just wanted to draw your attention to see how different the different parts of the country are. So you can see out on the West Coast, they don't necessarily have that issue that we're having on the East Coast as far as the overall epidemic for opioids. But then you see right there on the East Coast, which is getting hit, or northeast part of the country is getting hit hard with the opioids. Therefore, the concern here in this side of the country that we have this epidemic that's going on. But I just wanted to show you the regional threats, and just so you could see where the country is being hit the hardest. Unfortunately, I don't need to explain this, but I'll do a little bit. This is, again, overall within the nation, but you can take those percentages and probably bring them down into Kentucky, and you see the same results. And it just happens, I want to solidify some of the comments that you two gentlemen made, if you will bear with me for a minute. out since it's a hot topic and to let you know that it is a big concern. This is Narcan. And I give these as part of the DEA in my office. All my agents and TFOs have these kits that they maintain on their person for not only our use, but out in the field if something were to happen that we can, help somebody out in need and knowing that it's a vicious cycle. So I just wanted to solidify something that you two gentlemen had commented, that this is extremely important to be out there in the street to be able to respond to people that are overdosing. So just to bring that out there, again, just happenstance that I have that with me, so I wanted to present it to you all. So this is the best slide that I could think of presenting to you all to show the vicious cycle of how this works. So if I could ask just a real quick question, knowing that I'm with the DEA, how many out here think that the DEA's mission is primarily just to investigate and bust drug dealers, and that's all we do? I mean, be honest. I mean, because typically that's how it's been. I mean, we have been just forward arrest, and we've, unfortunately, it's taken us a while to figure this out. We can't arrest our way out of this problem. So therefore, we have to combine a number of different avenues to be able to support this problem. So typically, you'd see this gang distribution in the cartels. That's my job. That's the DEA's job. Typically, back in the history of the DEA and drug narcotics worlds, that's what we do. As you can see with this rotation of how all this works with the heroin addiction and the pill abuse, you can see that if we can break at least one of those off, we change the cycle. However, there's a number of different ways to go about it by helping out with the communities in the heroin addiction, supporting those and putting things in place to help out with the communities. And I'll show you here in a little bit how we, as a DEA, are working towards that. So around 2016, the DEA came up with a strategy called 360. And as you can see, it's three-pronged, and it encompasses exactly what the doctor has been talking about, as well as the commissioner. As you can see, our primary, and I say primary, historically it has been the law enforcement, local, state, and federal. But you can see that the DEA has, again, recognized the fact that we can't arrest our way out of this. Therefore, we have the community outreach and the diversion of the regulatory stuff that we're putting in place to help out with these communities. And I'll go into a little bit more depth on each of these categories. So the first one is something that we've been doing for a long time, and I'm going to reiterate with the commissioner's comments that we as an agency, the DEA, we don't have enough people to be able to combat the fight against the drug cartels effectively. So what we do to augment our personnel is we work extremely close with the state and local departments. For instance, KSP, we work hand in hand with them, as well as the local departments around the communities, and that just helps enforce the commitments that we have to the communities, that we are here to help, not only in going after the worst of the worst as far as the drug dealers, but to put things in place to help the communities recognize that there is a problem, and we can help each other get through it. So as you can see, the coordinating with the federal and state local resources, by combining our efforts, it opens up not only the federal resources, but it also opens up the state and the local resources to combine our efforts to make some progress. Some of the community enforcement efforts, I'm going to talk about a couple initiatives that have been put in place, and it may not necessarily, and it goes back to the enforcement of, so it may not necessarily go over extremely well, but I'll kind of get you to the point where we're trying to make people or help people understand that there is a serious problem, and we need to do something about it. So some of the initiatives that have been put in place, and the most recent one that I can think of is the Attorney General recognized that there's an issue throughout the country, so he initiated it's called SOS, which is a synthetic opioid surge. And what he's done is he's identified a handful of 11 or 12 different counties, and he happened to be that Lexington County was one of them that was identified. It means not a good thing, but it means that this area has been hit very hard with the opioid epidemic. So he's recognized that, and what that means is he's putting an additional U.S. attorney or assistant U.S. attorney in place to specifically go after smaller amounts of fentanyl, carfentanil, these synthetic opioid type cases that this area is seeing. So, for instance, a smaller 6 grams of fentanyl, or something on a lower level that in the state system they're not necessarily getting any kind of charge or any kind of time. With the federal system, we have a bigger hammer, and I say hammer meaning that we're able to make them understand that and get it out into the communities that we're not going to stand for the people that are doing these lower level types of drug deals that are putting them out into the individual users that are then therefore overdosing. So we're trying to make a mark within the community to say that the federal, state, and local counterparts, law enforcement, aren't going to stand for that type of activity. So it's just one way of trying to make a difference and hope that people understand that, you know, just by being a dealer that's distributing in smaller amounts doesn't mean that you're not responsible for putting this issue at hand and causing a lot of these problems that we're seeing today. And then another initiative is called the National Heroin Initiative. And this, again, is working with the state and local counterparts in investigating overdoses, the overdose deaths. Now, typically, back in the day, law enforcement treated overdose deaths as an accidental death, and wouldn't investigate anything further than that. These days, we're treating that like a homicide. So with that, we go through the regular investigative techniques with, in this example, Lexington or KSP, looking at the different avenues of what happened within that certain situation of the overdose. If we have enough information with that, we're charging, and currently having very good success charging these individual dealers that are contributing to the deaths of these individuals. We're getting very good sentences, and we're getting a lot of convictions. And again, I know not everyone likes to hear that it is law enforcement, it is putting people in jail, and it is arresting people. It's making a statement within the communities that we're not going to tolerate these drug dealers putting this stuff out into the streets and killing people. So I think those are two important pieces. And now again, I go back to, this is one facet of the 360 strategy. Okay, so this is just the enforcement portion of it. Now, where I get into the support of through the communities is the diversion partnership. And Doctor, you mentioned something about the prescription monitoring. So within the DEA back in 2009, in response to the up and coming, which ended up being the epidemic, the prescription opioid epidemic, the DEA created a tactical diversion squad, or I should say squads throughout the country, and that those type of groups specifically go after the diversion of pharmaceutical narcotics, i.e. registrants and pharmacies. And they've done, and as you can see in that previous slide that I had, in 2013, we've had a pretty significant decrease in those type of prescription type fraud when it comes to the narcotics or the diversion of the prescription medications. And then just most recently, you can see. Oh, I'm sorry, I didn't go through that next slide. That will help you a little bit. So again, I'm running a little bit out of time, and I want to cover a couple other pieces, so I'm going to kind of breeze through this. But you can see the mobile regional teams, the TDS teams, now are being deployed. We have 3, I think, currently within the DEA, and they're deployed throughout the hot areas like Kentucky, like Tennessee, like West Virginia, to be able to help with the TDS groups in investigating these type of crimes. So now I want to get into some of how we've changed in our mentality of going after this problem. And one of the biggest things that we've had some very good success with is our national prescription take-back program. And these next couple slides are going to highlight that. But really, what it comes down to is removing expired and unused prescriptions from the household, because I think we've all heard before that the majority of the time that's where it starts, is your kids at home grab a hold of unused medications and they take them off for their parties, and before you know it, it starts that vicious cycle of the addiction. So is it safe to say that the majority of the people here are from Kentucky. But I'm sure you're not necessarily born and raised in Kentucky. So if you take a look at this slide, and this is, again, I apologize, we're expanding outside of Kentucky, but pick the state that you're from. These are the sites that we had in these states to help work with the communities to take back all of these non-used, expired prescriptions and get them off the street, free of charge, no strings attached. Bring them in, drop them off, we take them and destroy them. And you can see the marks. Now, we've been doing this for 7 years. We do them twice a year. The last one we had was in April. Look at the number total weight we collected in one outing, 950,000 pounds. And that's just one take back. So you can see again, look at Kentucky, and then find the state that you're from. I think this speaks volumes of one way we can work together in a community, because we bring in the state, the local, the federal, the communities to help us with these programs to make it an honest effort within the communities. And then take from the start that we started this thing back in, again, 7 years ago, you could see the for the most part, a steady incline of the numbers that we're talking about taking off the street. So with that, I'll say that, let me go back that one. So the next slide I have is this date. I told you we do it twice a year. Last one was in April. This next one is in October. I brought a bunch of pamphlets in the back that I put on that table, so grab a pamphlet or grab a couple pamphlets and take them with you. Write the date on them and pass them out to people that you can think of that would benefit from this, and then pay attention to the date and the locations where you can take back your unused or unwanted expired narcotics. So then I wanted to finish off here, since I'm running out of time, is again this 360 program in 2016 kicked off with 4 pilot areas. And I will tell you that the DEA has since recognized that Kentucky, this area, West Virginia, Tennessee, Kentucky, have been hit extremely hard with the opioid crisis that's going on, or epidemic that's going on. So the DEA recognized that, and they have, since January of this year, we created 2 additional divisions. And previously, Kentucky was part of the Detroit Field Division. Tennessee was part of Atlanta, and West Virginia was part of Washington Field Division. With the creation of the Louisville Field Division now covers Kentucky, West Virginia, and Tennessee, to where you can see that we can now maximize our efforts having 3 states that we're in charge of to be able to fight this epidemic and work with the communities. So you can see on there, Louisville is one of those cities that was selected for the initial phase of the 360, and it was based on crime and violence. Now, since then, we learned a little bit of information from that. So as like everything, we progress. And in 2017, we opened it up to 4 more. And these were based off of a couple different aspects, because we learned how things were going, like overdose rates, relationship with state and local counterparts, U.S. attorneys, a couple different pieces like that. But you can see we're expanding. Now we're into 8 states. And still working at probably expanding throughout the foreseeable future to be able to bring what we do into the communities to help understand that it's not something that we can do alone, and we need the communities to help. I'm sorry, I had one more. So you can see it's still expanding in 2018 with these programs. So let me look at this last one, and this kind of encompasses all of what I'm talking about, the 360 program, is it not only brings in my agency or organization and other federal, because we're not the only ones that are combating this on the federal side, but it brings in all these different avenues and different community leaders, the partners, the church, schools. It's an all-encompassing aspect of what our world is today, and we understand that we need to be able to go past just arresting our way out of this. It's not going to happen. We have to bring in these different aspects to be able to fight this and work with the communities to help everybody that's a part of this addiction. So with that, I will finish off and just let you know this is my contact. Everyone with this stuff, be safe. I know I didn't cover too much of the fentanyl portion of it, but feel free to ask some questions during the next phase of this, and I'll try to answer as best as I can. But thank you very much.
This one on? Oh, it's on. Okay. They wired me earlier. No reference to DEA at all.
You won't know about that.
That's right. I don't know about that. I'd like to ask just one follow-up question of each of the panelists, and then I'll turn it over to the audience because I know that you all probably have a lot of questions for them as well. One of the questions, I'm going to start with you, Commissioner. I'd like to get your thoughts on, you talked about changing attitudes and changing attitudes across a couple of different populations. There are a lot of different attitudes that need changing, and one of the things that I heard discussed last week at the other conference in Seattle was stopping using terminology like clean, referring to someone as clean, because that implies that someone is dirty when they're not, when they aren't in recovery. Can you give some additional thoughts on ways that we can start to change that conversation, having experienced that within your own force?
Yeah, I agree 100%. I think I mentioned that. I do think we have to change the culture. And we can no longer refer to people with slang names as junkies or addicts. We've got to call it what it is. They have a chemical dependency, it's a medical condition, and they need help. So we have to do that.
Thank you. Appreciate that. Todd, I'd like to come to you next. Just heard a lot of talk about the federal partnerships coming into the local level. Has there been, a lot of times there's resistance to federal agencies coming in at the local and state level. Can you talk a little bit about, has there been the resistance, or is this problem so large that there's just been more of a welcoming of our federal partners coming in to step in?
I will say that here in Kentucky, they've absolutely accepted us in our roles as a partnership within this community. And I'm not just talking Lexington, I'm talking in Louisville, I'm talking in different areas. We have the support to even go as far as we just opened an office in Paducah, embedding into the community there, getting to know the local, state, officials there that are part of those programs that are helping solve this issue, and they've been extremely welcoming. Now, I can't say that is throughout the country,
right?
Because I don't want to go as far as to say that, but I will say that here in Kentucky, it has been all hands on deck to understand that this is a problem and we need to solve it together.
Okay, thank you. That's encouraging for us to hear, I think, in this room, that we're meeting it with optimism and welcoming. And then one question for you, Dr. B, just from a human services perspective. Our Cabinet for Health and Family Services, we frequently find ourselves on the reactive side of problems. We have to react. The example that I'll give is the child welfare system. Our number actually is up to 9,654 children in out-of-home care, and about 70%, don't quote me on that, but about 70% of children entering care are entering care now because of substance use disorder and opiates. What can we as a cabinet do better, and from a behavioral health perspective, being more proactive on these kinds of issues?
So I think the easy answer to talk about is that we need to communicate and share data. The harder thing to do is to define exactly what that means and how do we do that. But I think we've worked in silos to a certain degree, and one of the hardest jobs on this planet is to be a frontline DCBS family support worker and to and they are asked to do a lot, and they are making life and death decisions every day, and I think what we can do is better support them, give them the tools they need to do their work, but also make sure that we partner with them when they identify a family at risk due to substance use disorder, that they have the resources that they can refer those folks to. Because putting these families back together is going to be the key to raising our children safely. So I think that's the key, is better communication, working together, sharing the responsibility, and assisting our vulnerable families.
Thank you for that very much. At this time, I'd like to turn it over to all of you. I'm sure you have questions for the gentleman on the stage with me, so we'll take hands at this point. Questions? And I think, there's a microphone in the center of the room, so if you would just come to the microphone if you do have something that you'd like to ask.
Hi, I'm Keith Knapp from Bellarmine University in Louisville. Todd, Could you walk us through what happens to that ton load of drugs once they're collected, and what are the environmental concerns surrounding how they're disposed of?
Sure, and I'll speak specifically and I can speak for Detroit or Michigan, and I can speak for Kentucky as well, because I spent some time up in Detroit with the Tactical Diversion Squad, and we dealt with the same stuff. So typically, the function takes place on a Saturday, and we collect from the different sites. So in Louisville, down in London, here in Lexington, throughout the state, they'll be collected and they'll be brought to a central location, either to London, to Lexington, or to Louisville, and then we'll consolidate as an office or as a state, and we'll take those under our control. They're in our control from the time that they're brought to us on Saturday with all the drugs. We have people there with them, so we'll collect them, and then the local and state counterparts then collect their portions of them and bring them to us. So it's in state, local, or federal custody the whole time. Then we'll package it up and we'll take it to a facility in Indiana, and they burn it. So we don't bury it. We don't just throw it in the stream. We take it to a place in Indiana, and they do it for a fee, but it's worth it. And they'll destroy it in incineraries, and so they'll burn it. And Detroit was the same way. So it's not just, again, the one thing you don't want to do is flush the stuff down the toilet. Mm-hmm. So if you have any concerns, pack that stuff up and bring them to one of these dates that we have twice a year, and we'll take care of them free of charge.
I don't mean to hog the mic, but anybody that's worked with me knows how passionate I am about this. And Dr. Brenzel, I want to thank you. You've always been part of trying to find the solution. I know the last time we talked, and you mentioned it today, about having quality standards within the 1115 waiver. One thing I'm very passionate about is this is our most vulnerable population. There are some unscrupulous doctors and providers coming in and doing not so great work. And I know that you have an initiative to put in who are the quality treatment providers, and I know that you kind of talked about it before. Has that process started gathering people to say, what are these quality metrics? And then the other question I have is about the treatment stipend program. I know you didn't have a chance to really mention that, but that's really exciting, and I will be glad to get that message out. But is that just for nonprofit, or would that be for for-profit too, and would that also be for outpatient?
So first I'll maybe answer the second question. So the treatment stipend program is available to any provider, for-profit, not-for-profit, that is a licensed AODE BHSO, so they're recognized as a licensed treatment provider. Folks eligible for that are folks who are 150% of poverty level or below, and those can be folks who are uninsured or underinsured. It can be veterans, and it can be individuals who, for whatever reason, don't have another payer source. And so, again, Nancy and Operation Unite and her partners can help you get enrolled if you're a provider out there. The idea is many of these folks are Medicaid eligible, and we could reimburse in the interim prior to their eligibility, so that if folks come in, we would expect that other payers be exhausted or that they be enrolled in Medicaid, but we can fund the difference between the first 6 or 8 days if eligibility is an issue. And so the other question, you may have to remind me.
About quality. Have you started the process?
So there's a couple of reasons we're concerned about quality, basically because it's the right thing to do, but the 1115 waiver is requiring us, as a condition of approving our IMD waiver, we're expected to implement quality standards for those who will be eligible to expand. But also there was some legislation that passed in the last session that requires us to look broadly at our licensure categories. They're antiquated. They've been in place for 20 years when the problem was primarily alcohol. So we're looking at completely refiling our licensure requirements for residential with input from stakeholders. We want to eliminate this requirement for dual licensure, sometimes triple licensure. We want to make it easier for providers to come to Kentucky.
And I think we have 1 minute left, so we have time for one more question. And we'll go back to the... Are you yielding your time?
I'll make mine very, very quick. Thank you very much, all of you, for being here. My name is Robin Moreland, and I'm in Madison County. And I have two of the things that kind of hit me from our speakers this morning. One was seeing the trends back 20 years ago, and were we not responding? And I was on the ground as that DCBS worker 20 years ago burying an infant who had died due to its mother's Oxycontin abuse. So those of us, I think, here in this area were paying attention 20 years ago. One of the things that we are seeing as a trend, we talk about trends, right? We saw how the pharmaceutical companies were coming in and selling and pushing opioids. We saw that as a trend. We delayed our response, right? We're a little slow in responding, which is maybe why we're sitting here today. One of the things that we are experiencing and talking about a lot in Kentucky right now is our marijuana legalization. And for someone who has now worked with adolescents in treatment, with children, with families for 20 years now, I don't think we can skip over what the trend of legalizing marijuana would do for Kentucky. We have seen these issues, big initiatives that take lots and lots of money to bring in and to promote the message of how safe marijuana can be. I think we're going to hear about some of that later today. So I would love to hear from Dr. Brisnell as well as the KSP and any of you regarding, is marijuana one of those things that we're not going to fight now because heroin is so bad and we're going to fight that? So I would like to kind of hear your perspective on that as well.
I mean, I do think the good news is there's going to be a full panel this afternoon. I understand that it'll explore this issue. I will say that I share the concerns, particularly around those under 18 or under 21 in the states that have made decisions about liberalization of medical marijuana and even progressed to recreational. What we've seen is an untoward impact on school-age children, decreasing high school graduation rates. And so I do think it's a complex issue, but I also do share the concern that we safeguard our young people in particular, because it can certainly be a gateway to other drug use.
I will say on the federal side, is it still illegal? I'm sorry.
I think they heard it.
I'm sorry, can you hear me now?
Yes.
So I will say, as far as the federal aspect of it, it's still illegal. So we are going to continue to fight the battle, and we'll see how it progresses through, especially with the states. But as far as we're concerned, it's still a Schedule I, and that's where it's going to stay.
And I think we're out of time. No, I will just say this. Look, I'm certainly sympathetic to a 3-year-old that's having seizures. I'm sympathetic to those people. We have drugs now, Marinol, Epidiolex, those things that are extracted from the plant that I think are possibly useful. In no way will I ever condone smoking marijuana as a medicine.
And with that, we are out of time. I would like to, and seriously, that's going to be a very lively conversation this afternoon as well. So I'm sorry, do you have a quick question?
It's from a really different perspective, and I think it's worth stating, so I'm still here. So Alex was talking about recovery capital. And I say, so how can we encourage people with leverage to kind of, he said, the other guy was saying, we'll use leverage to get somebody into treatment and then the heart can follow. So police, DCBS, medical, also family have leverage in the relationship with people in active addiction to make moves that increase the recovery capital and the chance to actually recover, rather than using the leverage to push them into crisis without offering real tools. My husband's in addiction, is in recovery. I've been through it with DCBS, I'm in jail, and the whole scene. And it's really hard. I understand it's really hard to offer financial, housing, relational, and community tools to help somebody recover. But when I hear about charging people with homicides for the deaths, of people in overdoses, it has another side where 50% of the people who are being charged in those kind of cases are actually loved ones, family, friends who are in active addiction of the user who died. They could have bought drugs with that person. They didn't die. The other person died. And so there's actually there's a Yes Magazine article about a do not prosecute, people signing advance directives, do not prosecute my people for my death. But it's another case where people with leverage have this punitive angle because it's so much harder to offer somebody capital to be able to get their way out of it. And like I've been through it clean, and then I've been through the cycle, and I've had the experience of helping somebody get to a strong place in recovery, and it just like, it's another word about this mental shift that we need to go through. And I think it also affects prevention work in schools, where like my son is having a really awful time he has no relationships with the teachers. He wouldn't accept a prevention message from school because he sees people, it's just math, reading, teacher, test monsters, and not mentorship. So that's what I'm trying to get at.
And I'll just make one comment, and briefly, since we're out of time. But you do point out how complicated this is. But I will tell you that I travel a fair amount, and I am incredibly proud that our Justice and Public Safety Cabinet is our most committed partner to developing access to treatment. And you can't talk with our justice folks without them saying repeatedly that incarceration is not the answer. We're not going to arrest our way out of this. And they operate 6,000 treatment beds within the correctional system. And so it is coming from the top. I think it's also coming from the community, but you're absolutely right. We have to understand where people are. We have to recognize that diversion from law enforcement and arrest and incarceration and criminal record, and their inability to be employed, losing access to voting rights, the other things that go along with once you have a conviction, we've got to intercede and intervene prior to entering the justice system. And we have the commitment of our justice partners to do that.
We do. And thank you for that comment. I think it's a good place to end because of the multi-jurisdictional and just the cross-cabinet, cross-community, cross-agency work that this is going to take all of us, and your commitment to being here today is a part of that, and their commitment to sitting up here on the stage and discussing their parts in this really reflects a change in our direction here. Thank you all.